I know it's early and we're just kind of getting started in the course, but we got a lot of great content to cover. So now that you know how to take an exam and get everything right, let's review a little bit of content to get you started. So my name's Peter Sokolove. I work out at UCSF, and really pleased to be here to kind of cover a bunch of fascinating topics for you over the next couple of days. I will be talking with you about derm emergencies today. We'll also be talking about neuropsych emergencies today. And then tomorrow I will hit you with everybody's favorite one, which is endocrine emergencies. I know you're all very excited for that moment, so just keep the anticipation going, all right? So, you know, with the exam, dermatology clearly is something that's a visual part of our field, right? So this is a great opportunity for visual exam questions for the boards. So we're going to look at some of these photos. Some of these you're going to be able to look at and know exactly what it is. Sometimes it's a little, you got to think through it a little bit and really read that stem of the question. But they can ask you about, you know, what is it diagnosis, how do you treat it diagnosis, how do you treat the diagnosis, you know, what are the causes? So we're going to make sure we cover the important data as well. Now again, this is really meant to be not diving completely deep into each one of these rashes and disorders, but hitting the broad points for you so that you remember this stuff and you can do well on the exam. So with that, let's go ahead and get started. And let's start with some easy, familiar stuff, which is eczema, right? Atopic dermatitis. You all know about this. I'm sure you see this all the time. You remember that it comes as a triad where you've got atopic dermatitis, also associated with asthma, and also associated with allergic rhinitis or hay fever. So again, if you got somebody with a rash and you're thinking maybe it's eczema, but you're not sure, ask them if they have any history of hay fever or asthma. It just might help tip you over towards that diagnosis. Again, I think you know what this looks like. It gets red and then it gets very, very itchy. In fact, they call it the itch that rashes, because the more you start itching it, the more the rash starts coming out as well. So it gets red and then it gets crusted, right? So you get the crust, the fissures, excoriations all over it, and it can really, the crust can build up so much that you get lichenification where it's very, very thick. In adults, remember, there's classically, it says predilection for the antecubital fossa, the popliteal fossa, so you're definitely going to want to look for the distribution as well. Again, worse in winter, you can have a positive family history, lots of dryness, we talked about that. Okay, infantile eczema can look just a little different. It's the same sort of redness and, you know, scaling and crusting, but it may predominantly be on the face. Kids, especially infants, tend to have a lot of it on their face, and I'll show you a picture of that in a moment. It can be elsewhere, but the face would be a good spot for it. Okay. Treating eczema, pretty simple. Topical corticosteroids, something for the itch. Complications, well, of course you can get a secondary bacterial infection. That always makes sense. But don't forget about this thing we don't see that often, called eczema herpeticum. Eczema herpeticum is where you actually have herpes simplex virus on top of your eczema, okay? So you got your kind of group vesicles, your HSV, right on top of a patch of eczema. That's eczema herpeticum. So here's some nice pictures. Here's eczema. Again, this looks like an antecubital fossa to me. You see a bunch of thickening of the skin there, some kind of excoriations there, right? So that's pretty classic for atopic dermatitis. This is infantile eczema. Lots of redness and scaling on the face of this little kid, you know, scratching at its face, that sort of thing. There's not a bunch of honey-colored crust here. This is not impetigo. This is more of an allergic thing, right, with atopic dermatitis. And here, again, it's another adult with a scaling rash, and it's, you know, hard to know exactly what it is. Lots of things can be scaling, but if you kind of look at the antecubital fossa on both sides, you'll see that there's a good patch right there. It's just another hint that there is actually atopic dermatitis as the cause. Okay, and here's a popliteal fossa. Again, you can tell that's been itchy, and now actually we have hypopigmentation because of all the inflammation that's been going on. So you can see that as well. Okay, simple stuff. Contact dermatitis. There's a couple different types. There's a thing where you touch something and you get a reaction immediately. And then there's the allergic contact dermatitis where it takes a little more time to get it, where it's a delayed hypersensitivity. These are your poison ivy, poison oak, poison sumac, things like that. Nickel-plated jewelry would be a real common one for a contact dermatitis. Hair dyes, different detergents, things such as that. And again, it's going to be red. You're going to get some maybe little vesicles or bullae even. There's not antigen in there. It's just an allergic reaction, right, to the thing that you touched. And you may use steroids for more severe cases. Pretty simple. Here's a contact dermatitis. You see some redness there. You see some like little mini vesicles. The thing that's a hint to me that this is a contact dermatitis is you can see in that one spot there's a linear kind of area there of the of the little vesicles right in the middle there, that little linear area of the vesicles. Whenever you see any sort of rash that's linear, I think about a contact, because it's almost as though you brushed up against something, and that's what kind of made the line on you. So whenever you see something linear, at least through your mind, think about a contact dermatitis. Honestly, this looks a little more like cupping to me than contact, but they're telling me it's contact, so there it is, okay? Something in that distribution must have touched them. Here's a good one. You can see right where this person had this watch, they've got the thickened skin and the scaling and that sort of stuff going on there. It's probably a nickel-plated back of the watch, classic for a contact dermatitis. So that's simple. And again, here you see some redness, some little vesicles, and you see the linear part over there on the slide, towards the left of the slide, a hint that it's probably a contact dermatitis. And there's your poison ivy. Grows very well. Actually, where I live, poison oak grows wonderfully. Right behind our house, we've got this little hill, poison oak all over the place, comes up, comes down, really bad stuff. By the way, you can get an inhalational injury from this stuff. Some people may have seen this when you're cleaning out the poison ivy or cleaning out the leaves and someone goes to burn it, and you can actually get an inhalational exposure from that. So I don't recommend it. Not fun. Okay, exfoliative dermatitis. This is something we don't see every day. In fact, we don't see it, often at all. Exfoliative dermatitis, I like the name exfoliative erythroderma because that's kind of what reminds me of it. This is basically a diffuse generalized dermatitis where someone is going to get red and then scaly and then peeling skin all over, okay? And this is going to be an adult, right? So it's an adult with diffuse, scaly, warm, red skin all over. There's usually some sort of underlying disease that's going on. And when you see this on the exam or in life, I want you to think of a couple kind of key things. One is any sort of drugs that could be going on, chemicals that is, right? Or malignancies, particularly lymphoma, leukemia. Okay, so somebody, male over 40, you get a 45-year-old male, comes in, red all over, scaling all over. Think about, what they're on and what medicines they're on, and lymphoma and leukemia. Okay, complications shouldn't surprise you, right? You got red peeling skin, so you're going to get volume loss, heat loss, secondary bacterial infection is possible, electrolyte imbalance, things like that. They're sick, they get admitted, IV steroids, etc. Okay. So this is exfoliative dermatitis or exfoliative erythroderma. You see the kind of red palm on the right side of the scale of the slide, and the peeling on the left side. This is just imagine that going on all over the body in somebody over 40. That's exfoliative dermatitis. Psoriasis is a very common disorder, and this is a really good visual diagnosis one because the appearance of it really can look very, very classic. One of those things where you look at the question, I know exactly what that thing is, all right? So remember, this is a chronic papulous squamous eruption. So basically the skin cells are turning over more rapidly, and they're building up, and they're building up, and they're forming these big, thick plaques. And they're kind of these white, silvery, kind of scaly plaques, classically on the extensor surfaces, but they can be on the scalp and the genitals and the body, lots of places, but extensor surfaces would be a classic place for an exam question to see it. Again, white, silvery plaques, extensor surfaces. Look at the fingernails. They may have pitting of the fingernails, which can be associated with psoriatic arthritis as well. And again, lots of different treatments for psoriasis, steroids, tar, UV light, and methotrexate, lots of different things that can be used. But I think most important is to be able to recognize this one for the exam. And here you go. It's an extensor surface. You got a knee. You got a big, scaly, kind of, well-demarcated plaque there, very white, silvery. That's pretty classic for psoriasis. And here's some nail involvement on that photo, which you guys have as well. These little fingers here, but little scaly, white, silvery plaques. Psoriasis is going to be the answer. Okay, sebderm, seborrheic dermatitis. This is dandruff. This is, you're wearing your dark suit, scaling in your head, and it's just, flaking off, little white flakes all over your suit. But it can also have a different appearance that can look yellow and waxy, and I'm going to show you that picture in just a moment to explain it. But what is seborrheic dermatitis? Again, it's just this little flakes of skin coming off your scalp most of the time. Scalp, eyebrow, ears, things like that. It's associated with a fungus, Malassezia. So Malassezia is the fungus that's associated with dandruff, with seborrheic dermatitis. It's not contagious. You're not passing it person to person, but it is associated with this fungus, and getting rid of the fungus helps get rid of the disorder, okay? Frequent recurrences, especially in cold weather or during winter, things such as that. Where are you going to see this? Well, classically, you're going to see it up in the scalp. But remember, it can get on your face with seborrheic dermatitis, and when it's on your face, it's what's known in a T-shaped distribution. So it's around the eyebrows and on the sides of the nose. So it's like a T on the face. T-shaped distribution when you see it on the face. And seborrheic dermatitis can get down onto the body as well when it's severe. So we think about it as dandruff, but it can also get on your face with the T distribution. And when it's bad, it can get on your body as well, okay? If HIV positive individuals can have pretty severe seborrheic dermatitis. Obviously, most patients with dandruff aren't HIV positive, right? But if you see somebody who looks cachectic and they got a really bad case of seborrheic dermatitis going on, think about HIV infection. Okay, treating dandruff is basically anti-dandruff shampoos, either the over-the-counter stuff or ketoconazole shampoo, basically trying to get rid of that Malassezia fungus associated with it. Okay, here's some pictures. So if you look kind of just above the ear there, you see some little white flakes at the hairline. That's seborrheic dermatitis, classic dandruff. We've seen this, I'm sure, many times. This is that yellow waxy appearance that I was telling you about. This is the same thing. So even though it's not little white flakes, this is seborrheic dermatitis treated the exact same way. Almost looks like kind of, melted yellow candle wax or something there at the hairline. Same disorder. Okay, pityriasis. Pityriasis rosea. This, is usually kids or young adults. No one knows exactly what causes this thing. It's not coming in epidemics. It's not contagious, but it just seems to happen. And if you remember the story with pityriasis, kind of the way it evolves, the first thing you get is that thing called the Herald patch. So the Herald patch is this 1 to 5 centimeter kind of circular or oval shaped, pink salmon colored patch on the trunk of the patient. All right, and it's called the Herald patch because it heralds the arrival of the rest of the rash. So you start with the Herald patch, and then 1 to 2 weeks later, you get the rest of the pityriasis rash. And they're basically smaller versions of the Herald patch, little, 1 centimeter pink oval sort of shaped lesions on the trunk. And classically, of course, you remember that they're in that what distribution? The Christmas tree distribution, exactly, which I'm sure looks exactly like a Christmas tree to all of us when we see it, right? Not exactly. So anyway, the classic Christmas tree pattern, which is where the little lesions are lining up like ornaments on the limbs of Christmas trees. So they're kind of doing this sort of thing, symmetrically on the body, like the limbs of a Christmas tree. That's the classic Christmas tree pattern. So you start with the Herald patch. A couple weeks later, you get this little Christmas tree distribution of these little smaller patches. You got to think about syphilis, right? You got to at least have it on your differential diagnosis because it can look like that. Secondary syphilis can look like this. Pityriasis is never going to involve your palms and soles. Okay, if it's on your palms and soles, it's not pityriasis. Don't shake hands. Wave. Okay, that might be secondary syphilis. So you got to be careful about that in the right patient population. Treatment is pretty much symptomatic. Not much to do about this one. It'll resolve on its own. So let's look at some pictures. So here's an individual where you can clearly see the Christmas tree pattern, right? All right, it's kind of hard, but you see these little, circular dots that are kind of lined up like the limbs of a Christmas tree is the idea there. You got to hallucinate. Squint real hard. See if that helps. Okay. Again, same sort of lesions, these kind of, you see the size and the shape of them, these kind of, oval, round sort of things. There's a little scale on them. By the way, if you were to look really closely at this, the scale classically is around the circumference of these lesions. It's not like scaly all over the thing like we see with most things. It's called circumferential scaling basically there. That's another sign that it's pityriasis. And again, there's a Herald patch. You can kind of get the sense that the scale is circumferential on that one. It's hard to tell. Okay, that's pityriasis. Pretty simple. Okay, Petechiae and purpura, again, you know what this stuff is, right? So when you get a red rash, first thing you're trying to figure out is it blanching or non-blanching. If it blanches, it just means it's vasodilation. If it's non-blanching, it means that there's some blood that actually got outside the blood vessels and that's causing, right, petechia, purpura, bruising, things such as that. So these are non-blanching rashes because it's blood that got outside the blood vessel. Kind of by definition, if they're less than 3 millimeters, they're petechiae. They're more than 3 millimeters, they're purpura. Okay? And the first thing you want to do when you see these lesions and when you see, hey, is it petechia or is it purpura? The next thing you want to do is say, is it palpable or not, especially if it's purpura. So if it's purpura, the question is it palpable purpura or non-palpable purpura? Because that's a really important branch point in what may be causing it. Palpable purpura equals vasculitis. It doesn't tell you the etiology of the vasculitis, whether it's HSP or infectious or whatever it is, but it does tell you there's a vasculitis going on. So again, first thing, is it blanch or not? If it doesn't blanch, it's either a petechia or a purpura. Is it's less than 3 millimeters, petechia, greater than 3, it's a purpura. And if it's a purpura, is it palpable purpura, which is vasculitis, or non-palpable purpura. Those are the things you want to figure out. Treatments obviously depends on what's causing it, so nothing to memorize from that on the slide. So here's some petechiae. Again, you know these little petechiae, maybe one purpura there over the what is that, fourth distal metacarpal there, perhaps. All right, these are some purpura, bunch of those, getting bigger now. You can see that. Can't tell for sure what's causing that, although by the distribution, maybe HSP, it's hard to tell. Okay, Urticaria. This is hives. Pretty simple. You see this all the time in the emergency department. Hives comes from the Saxon word for heaven. That's how it's got hives in heaven. The Saxon for hives means to raise up. And these are raised lesions, right? So the wheels that you see with hives are these kind of raised, kind of cloud-like looking lesions. So again, superficial edema. So this is superficial edema, not deep edema like angioedema. This is superficial edema. You get the wheals and the redness. Oftentimes we don't know what caused this, but we do know that it's IgE mediated. So hives, the things to remember are that it's IgE mediated. It's an allergic thing, right? It's IgE mediated where you get mast cells that degranulate and release the histamine. And the other thing to remember is that it's superficial edema. When you're looking at urticaria and you're looking at these wheals, remember that these things move around. The rash of urticaria, if you were to look at any particular lesion, it should not stay in the exact same spot for more than 24 hours, okay? So the whole rash may be more than 24 hours, but they tend to move around. So ask the patient, that little spot right there, has that been sitting there for the whole 3 days, or is it kind of coming and going and moving around in different spots? It should be moving when it's hives. Okay, you know how to treat this. It's self-limited stuff for the most part, antihistamines, steroids, H2 blockers, maybe epi if you really need it, that sort of thing. Usually don't. So that's urticaria. You can see these nice, kind of raised geographic lesions, pale in the center there. Very classic, the edema going on in the middle there. I love this one. The center of the slide is normal, the white part in the middle is normal, and the rest are the raised wheels, okay? So you can see why they called it heaven, like hives in heaven. It looks like a cloud. That's urticaria, pretty simple. Angioedema is also edema, right? We know about that. But the difference here, in contrast to hives, it's bradykinin mediated. So it's not IgE, it's bradykinin mediated. And the edema is down deeper in the dermis. So it's deeper edema, and it's bradykinin mediated, not IgE mediated. And as you know, there's various different types of angioedema, two types that you really need to be aware of. The first is ACE inhibitor angioedema. This is somebody who's on an ACE inhibitor, and now they present with angioedema. Usually it'll occur within a week, but it can be years. So it doesn't have to be that they just started it. They could have been on it 2 years, and they just came in today because you were on, and that's the way it works. They got their angioedema, okay? And what happens here is that this, again, bradykinin mediated. So the ACE inhibitors are inhibiting the metabolism of the bradykinin. So you get bradykinin buildup. So bradykinin, deeper in the dermis, ACE inhibitor angioedema, it can be hours or it can be years, and you just got to stop the ACE inhibitor. That's the most important thing you're going to do for that one. Familial angioedema is another important one. This is the one associated with C1 esterase inhibitor deficiency. So you've got the C1 inhibitor deficiency. You don't have the C1 inhibitor, and you start to build up bradykinin. So again, it's all bradykinin mediated with this angioedema. This is an important one because it requires a special treatment. So the great thing is if you could just give them the C1 esterase inhibitor back. So if you can give them C1 inhibitor, that's great. If you don't happen to have that sitting in your Pyxis or at the bedside or whatever it is, okay, you could also treat it with FFP. Okay, so either give the C1 inhibitor back or go ahead and treat it with FFP for the familial angioedema. And the thing about familial angioedema, it presents a little differently. These are patients who come in with recurrent edema of the face, there can be extremities, the bowel wall, so they get a lot of abdominal pain, they get a lot of facial swelling, and they can get a lot of laryngeal edema. That gets our attention, right, because of airways. So facial swelling, laryngeal edema, abdominal pain. So again, be really careful with those folks. Sometimes with the abdominal pain stuff, you need to get some opiates and to give them lots of fluids because they're losing their fluids as well. So that's the two types of angioedema I want you to know about. Bless you. And here is a nice picture of angioedema, right? This would be a classic question, whatever, 40-year-old African-American female with a history of hypertension presents to your ED with swelling, blah, 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 right? What's going on with this patient? It's an ACE inhibitor. They gave you the hint with the hypertension. And I told you how to treat it. This is one of those scareways, right? This can get pretty bad. What I like to do when I get one of these, first thing is you get the airway box. And the second thing is you look how close it is to sign out, okay? Because maybe they need a troponin or a urine or something like that set. You never know. Just kidding. Okay. Erysipelas. Erysipelas is pretty simple. Erysipelas is just cellulitis, and you know what cellulitis looks like. But erysipelas is a special cellulitis that's caused by group A strep, classically, okay? So erysipelas, think group A strep and cellulitis. And you know what cellulitis is, so it's red, warm, tender, that sort of thing. It tends to be on the face or the extremities. But the thing about it is it has a well-demarcated border, classically. So you know how when someone's got cellulitis and you're trying to draw that line around it, you can never kind of figure out exactly where to draw it, where the edge is? Well, with erysipelas, it's a well-demarcated border, so it's much sharper on the border there, okay? So classically, maybe an elderly patient got this rash on the face. It looks and feels like cellulitis. It's really well-demarcated. It could be group A strep, meaning it could be erysipelas. And because it could be group A strep, penicillin actually could be the right answer for treating this, right? We never treat cellulitis with penicillin in general. It's crazy, right? It could be staph. But if it's erysipelas, if they really think it's strep, and if that's what's in the stem of the question in any way, penicillin will work for that one. Okay, elderly patient, red rash on the face, it's painful, and you can see the border looks pretty well demarcated. You wouldn't have any difficulty drawing a pen line on that one. Penicillin. Okay, erythema nodosum. I love this. Red nodules, right? So erythema nodosum, what is this? This is somebody who's got, like it says, it's red nodules. This is a paniculitis. It's inflammation of the fat is what that is what paniculitis is. Inflammation of the fat. So they tend to get these kind of deep, red, very tender nodules, classically in the pretibial region. That would be the classic place to see that. So you see somebody who comes in and they got a bunch of, redness or even kind of purple violaceous look in the front of their legs. You want to think about erythema nodosum, okay? Now, you're kind of proud of yourself. Ooh, I figured it out. It's erythema nodosum. But the real challenge isn't figuring out that it's this. It's what's associated, what's caused with it. So when you see erythema nodosum, it's a marker of some systemic disease. And that's kind of where the next hunt begins. And you should know some of these things associated with it. So it could be a drug reaction. I don't think you have to memorize a list, but lots of things can cause it. Systemic infections like TB or fungal infections like cocci, right? Coccidiomycosis would be a classic one for that. Sarcoid is associated with erythema nodosum. IBD, inflammatory bowel disease like ulcerative colitis. And then malignancies, lymphoma, leukemia, that sort of thing. So you see somebody with erythema nodosum, now you need to work it up and try to figure out what the cause is of this. Very common in women, kind of 30 to 50 age range, resolves usually on its own in a number of weeks. The treatment is really directed at the underlying disease, right? It's not about the erythema nodosum itself. So here we go. They're showing you a pretibial region. That's the first hint right there that it's erythema nodosum. It's red. It kind of looks like it's probably a nodular sort of thing. If you were to touch it, it's going to hurt. Ouch. Again, patient coming in. That's the same thing. It's erythema nodosum. You're taking the history right on this patient. You're like, what happened? What'd you bump into? The coffee table or something? They're like, no, didn't bump into anything. You're like, come on, you bumped into something. Nope. You sure you don't remember? Nope. Did somebody hit you with the bat? Nope, nobody. Are you safe at home? I mean, like, you're asking all the questions, right? Because this looks like somebody hit you with like a stick or something, but it's actually erythema nodosum. Okay. Drug eruptions, the only thing that I want you to know from this slide, there's a lot of words, but not a lot to know, okay? The main thing about drug eruptions is that I want you to consider a drug eruption anybody who presents to the ED with any acute symmetric rash. So any acute symmetric rash, you just got to think about drug eruption. And it can look like anything. It can be vesicular. It can be, morbilliform. It can be urticarial. It can be IgE-mediated, IgM-mediated. You don't have to memorize all that stuff. The bottom line is any acute symmetric rash, you got to figure out what meds they're on because it could be a drug eruption. And obviously, you got to get rid of the drug if that's what's causing it. Okay, the next three things I want to talk about, erythema multiforme, Stevens-Johnson syndrome, and TEN, toxic epidermal necrolysis. We used to think about those as three separate things. They could be totally separated in the derm lecture, right? But the more modern thinking about it is that it's actually a spectrum of the same underlying disease. And it's kind of the same sort of things that tend to cause them, okay? So erythema multiforme is kind of the minor cause, or minor form, I should say. Stevens-Johnson syndrome is when it's getting more severe of it. And then TEN is when it's really maximal and very, very severe of the same spectrum of the same illness, if you think about it that way, okay? Lots of things can cause it. So erythema multiforme could be something mild, like you got a little herpes on your lip or a little mycoplasma infection in a little 10-year-old or something like that, and now they've got some erythema multiforme. Pretty benign on its own. It's not a big deal. Remember what it looks like. The classic lesions are the target lesions, the bullseye or target lesions. So kind of red and white lesions, oftentimes on extensor surfaces. They can involve the palms and soles. They can be lots of different regions. Look for the target lesions. And again, the idea here is you got to get rid of whatever's causing it. So get rid of the medicine, treat whatever was underlying it there. Erythema multiforme itself is usually minor and can be discharged. It's not that big of a deal. So here's some erythema multiforme. You see the lesions. You kind of get the sense that there's almost like a target in the middle, that there's something going on different in the center than the rest of it. But I really like this picture. This is really a great example of erythema multiforme and target lesions. Again, you can see it there. You got some involvement of your palms as well. And again, this tends to be a symmetric rash. This is not just going to be on one hand. It's going to be on both sides, to some degree at least. Okay, Stevens-Johnson syndrome is now when it's kind of more involvement. You've got like maybe 10 to 30% of the body surface area involved. So you got more involvement, or you can have mucous membrane involvement, or you can actually have the bulli starting to form, which is kind of bullous erythema multiforme. Think about it that way. Now you're in the territory of Stevens-Johnson syndrome. So more body involvement, oral involvement, mucositis, as well as potentially bulla. Okay, same sort of things that cause it. Here's the pictures, right? That's a classic exam picture. The lips look really eroded there. That's Stevens-Johnson syndrome. Classic. Here's another one. You know, again, it's hard to tell exactly just from the rash that it is Stevens-Johnson, but if they give you the, person just got started on a new medication and now came down with this rash, and you can see how much there's there. There's a lot of it involved now. So this is probably beyond erythema multiforme and into Stevens-Johnson syndrome. Okay. And then TEN is the maximal, the real severe end of it. And what you have now with TEN is actually you have peeling sheets of skin. So then not only do you have a bunch of body surface involved, like more than 30%, and maybe you got a little bullae, now you actually have sheets of skin that are starting to peel off on these patients, okay? Same sort of things cause it, lots of, drugs, chemicals, things like that. Now, you remember about TEN. The cleavage plane for TEN is very, very high. It's at that dermal epidermal junction. So because of that, the peeling part of the skin on top is very, very thin. It's a very thin sheet of peeling skin. And that's why you get something called the Nikolsky sign. Nikolsky sign is if you were to take your thumb and if you were to just kind of like rub gently on the involved skin, it would just peel right off. It would become denuded. It's as though you took a tissue and put it on your, bathroom counter up in your room upstairs, poured some water on it, and then pushed. You know it's going to rip, right? It's that same thing. That's what a Nikolsky sign is. So it's high peeling of the skin, so it's a positive Nikolsky sign. Obviously, patients get very, very sick from this, and they need to get admitted, and they're essentially, have the same complications as a burn. You're just peeling all over, so they need ICU care. Dehydration, electrolyte imbalance, secondary infection, all those sort of things go on. So these are ICU admissions. Okay, so here's somebody, they're demonstrating for you the Nikolsky sign. They got that really thin skin, and you push on it, and it starts to peel off. By the way, I'm really hoping that is like the patient doing that on themselves, because otherwise, don't put your thumb like in the arm juice. No, don't do that, Put on a glove. Don't do that. Okay. This is a great exam question, right? I mean, that's an adult with big, peeling sheets of skin. Go directly to TEN. That is the answer. That's toxic epidermal necrolysis. Again, peeling sheets of skin in an adult. Okay. Now, Staph, scalded skin syndrome, is a tongue twister, is also peeling skin, but this is a kid. This is a little kid, usually under the age of 2. So you got a young kid who gets some Staph aureus, and the Staph aureus produces an exotoxin that causes cleavage in the exact same place that you get with TEN. So they also get a positive Nikolsky sign. They also get peeling skin all over their body. But because it's a little kid and it's a different etiology, the prognosis is much better than with TEN, okay? So young kid, Staph, cleavage plane, positive Nikolsky sign, same sort of thing. Here you actually give some vancomycin as well because you got to get rid of the staph. Doesn't actually change the skin disease, but seems like a good thing to do to get rid of the staph that caused that problem. So some vancomycin you're putting on there as well. Okay. Here's a kid with Staph scalded skin syndrome. Now, I will tell you on this slide, there's a lot of kind of yellow around the face there too. So I almost wonder whether there's a little secondary impetigo going on there. So let's not anchor on that part of it. But you get the idea that it's a young kid and that there's kind of scaling and peeling all over the body. This would be the great visual diagnosis question for the exam. It's a little kid, look at the size of the foot, and they got peeling skin all over. That's Staph scalded skin syndrome. Better prognosis than TEN in these young kids. Okay. The next two things I want to tell you about. All right. Don't throw things at me. Pemphigus vulgaris and bullous pemphigoid, okay? And I know you're thinking, like, I went into emergency medicine to not have to think about the difference between these two things. But just till we get through the exam, let's just kind of know a couple of trivia points. And then, all right, you want to forget it again later? Fine with me, all right? So let's make it simple. Pemphigus vulgaris and bullous pemphigoid. These are both autoimmune bullous disorders. So in both of them, it's autoimmune, and both of them you're going to see some bulli. But one of them is more benign, and one of them can be more serious, okay? Pemphigus vulgaris is the one that can be more serious. And the way I remember that is, vulgaris, vulgar, bad. And I know those of you who speak Latin or know Latin, that's not what it means, but okay. But think that's the way I remember it at least, right? This is the bad one. Pemphigus vulgaris can be the bad one. So these are painful bulli. By the way, things that are painful are bad too, right? So it's painful and it's bad. Usually kind of 40 to 60 years old. And they often start with bulli in the mouth. Now again, anything where you got peeling or bulli in your mouth is generally not a good thing as well. So it kind of helps us remember this all together. The painful, the mouth, that it's the bad one, they all kind of go together. And these blisters, these bulli, are very fragile. They break very easily. You know why? Because the cleavage plane is the exact same place as TEN again. Does that make sense? So these are very, very fragile blisters that will break very easily. And also like TEN, this is the bad one. So it kind of all makes sense when you think of it that way. So blisters start in the mouth. They're painful. They're fragile. They break pretty easily. They're very superficial, so you're going to have that positive Nikolsky sign again on the top of that blister. And again, same sort of complications, right? Infection, dehydration, etc. They're admitted. They may get some steroids. Okay, so this is a bulli. You can see it's very, very thin, and you can see that one of them is already denuded there. So that's Pemphigus vulgaris, the bad one with the thin bulli. That, you can see why it's bad, right? Big bulli, peeling, bad. That can't be good. Now, bullous pemphigoid is more of a chronic and benign thing seen in patients who are a little older than with the vulgaris. So these tend to be patients over the age of 60. They may be on Lasix or something like that, which also may be going with that. They also get big bulli, large 2 to 5 centimeter bulli, but the cleavage plane is much thicker. So these tend to be opaque bulli. These tend to be thicker bulli that don't break so easy, that are going to have a negative Nikolsky sign, and you're not going to have so many complications. All right? Kind of makes sense. So this is bullous pemphigoid. Again, big bulli, but look, these are thicker, more opaque. They don't look like they want to just pop any second right in front of you. All right? That's bullous pemphigoid. So that's the difference between those two. Again, summarize. Pemphigus vulgaris, the bad one. Fragile, small blisters may start in the mouth that are oral. They can be bad, positive Nikolsky. Bullous pemphigoid, chronic eruption, elderly patients, larger blisters, more benign, thicker blisters, negative Nikolsky. Okay, now you'll get all those questions right for the exam. All right, let's do a couple of skin cancer things here and whip through these. All right, we're going to do basal cells, squamous cells, and melanoma. So let's start with basal cells. Basals are the most common skin cancer. And when you look at them, sometimes it's hard to tell them apart from the other ones, at least for me. I mean, I'm not a dermatologist. But they tend to have this kind of pearly, kind of rolled border. Almost looks like rolled up, kind of rolled pizza dough at the edges or something. It's very pearly appearance to it. They sometimes will have central ulceration in the top of the basal cell carcinoma. These are slow growing. It says not metastasizing. It's very rare to metastasize. It can, but it'd be very, very rare. They usually don't metastasize. They're slow growing. They're usually on the head and neck. They are seen where you have hair follicles. So you're not going to see a basal cell on your tongue, right? You don't have hair follicles on your tongue, at least as far as I know. So you're not going to see a basal cell on your tongue. You could see a squamous cell on your tongue, but not a basal cell on your tongue. Okay, and again, the cure rate's pretty good if you get these out. That's fine. So here's a really beautiful picture of a basal cell carcinoma. It's got that pearly look to it. It's kind of rolled up there at the edges, right? Kind of heaped up. You see that central ulceration. And frankly, if you were to look really closely right over the top, you'll see little telangiectasias, little branching blood vessels over the top. That's another hint for these basal cells. That's a perfect picture. That's the one I remember for what a basal cell carcinoma is supposed to look like classically. Here's another one. Still a little pearly, a little rolled up, little central ulceration. Okay, that's the basal cells, most common ones. Melanomas you know about. These are the big bad ones that we worry about because these are the ones that are most lethal. So they're the most rare of the skin cancers, but they're clearly the most important ones, the most lethal ones. Risk factors, lots of childhood UV sun exposure, lots of sunburns, fair skin, a family history of melanoma, having it arise out of a congenital nevus, things like that can all happen. Again, this is one that causes the most skin cancer deaths. If you remember, the deeper it is, the worse the prognosis is, and because, of course, melanomas metastasize, and we got to be very careful about picking these up early if we can. This is a melanoma. This is a really impressive looking one. But the thing I remember about melanomas, right, they tend to be hyperpigmented and they're irregular. So they're irregular in lots of different ways. They're irregular in their shape. They're irregular in their topography. They can be irregular in their color. They tend to be bigger than the eraser on a pencil. So they're bigger than 5 millimeters. When you're looking at some, 2 millimeter brown dot, probably not a melanoma. But, 5 millimeters, bigger than 5 millimeters, looking irregular, you got to be concerned. Again, this is a classic, what's called superficial spreading melanoma. You can see the borders are irregular, the colors are irregular, some dark, some light, some pale. Topography, there's some flat, there's some raised. This really makes you think this is a melanoma. Don't want to lose this one to follow up for sure. Okay, and then squamous cell carcinomas, second most common, tend to be elderly patients who've had a lot of sun exposure, so it'll occur where there's sun exposed, your face, your hands, your construction worker has been working outside his whole life, has now got a squamous cell lesion on the face or on the hands or things such as that. Again, these can metastasize, so you want to treat these for sure, and again, they may excise them, they may do radiation, they may do, 5-FU cream. There's lots of different things that they can do for this. But face, ears, lips, tongue. There's a squamous cell carcinoma on this elderly patient. Again, sun-exposed area. And there's another squamous cell. Squamous cells almost looks like it wants to grow a horn on top of that one, right? So you can tell these are kind of squamous cells piling up, not that same rolled border that we have with our basal cell. Okay, so those are the skin cancers. Let's talk a little bit about tinea. These are the dermatophyte infections. You got your tinea capitis, your scalp, your tinea barbae, the beard, tinea corporis, which is the ringworm on the body, tinea pedis, athlete's foot in between the toes, really itchy, you know about that, tinea cruris, which is the jock itch, right? So the scalp and the barbae, when you got hair involved, you're going to see some scaly patch, and you may see, of course, some alopecia, some lost hair or broken off hair in that area. So when you see some hair loss, when a patch going on, think about a tinea infection. Remember, in kids who've got tinea capitis, they can get that big boggy mass on their head and their scalp called a carrion, which is basically just a big tinea capitis infection. Don't go in there and IND it, okay? Not what you need to do for that kid. That's just bad tinea capitis. Tinea corporis is ringworm. It's on the body. I'll show you a picture in a minute. You can see why it's called ringworm. It's an annular lesion that kind of spreads its way out on the body. Tinea pedis, it's the stuff between the toes, makes everyone crazy. Jock itch is on the groin and inner thigh. It's not on the scrotum itself, okay? So you got this, this itching and redness kind of going on in there, but it's not the scrotum itself. If your scrotum's involved, make sure it's not a scrotal cellulitis or something worse. What causes this? Don't memorize the bugs. These are dermatophytes, right? Trichophyton, microsporum, these sorts of things, these dermatophytes. So you treat them with antifungal treatments. So the general guideline is if it's something on the skin, you're using topical. If it's like the nails or the hair or something like that, you're using something oral. Okay. So tinea capitis, here's somebody with tinea capitis, back of the hair there, you see the patch, you see that there's some hair loss in that area. You're not going to miss that diagnosis. Tinea corporis, that's why it's called ringworm. I mean, that's a great picture of that, right? Annular lesion kind of working its way out. That's tinea cruris. That is not a blue scrotum. Do not panic. We're okay. We're okay. It's just involving the inner thighs there. Okay. Now, Pityriasis versicolor, this is one of those confusing things. We probably learned this as tinea versicolor, right? But this is actually not a tinea. This is not a dermatophyte infection like I was just showing you about. This is not. This is actually a pityriasis. This is caused by mollusacea, the same fungus that caused dandruff. And in many ways, I think about it more like as the dandruff of the body because it's mollusacea, and you treat it the same way, which is the antifungal or Selsun Blue, whatever type shampoos, that sort of stuff, right? Or Head and Shoulders, whatever you like. So what is this? This is the patient, you see him in the emergency department, and they got their gown on, and you're just doing their lung exam, and you just kind of notice these like hypopigmented or maybe even hyperpigmented, just kind of macules, kind of flat areas on their back. And you're like, have you noticed this? They're like, yeah, I kind of noticed it. It's been there for a while. I don't know what it is. So these are associated with poor hygiene and moisture. So, you've been wearing that same basketball jersey for the last week and sweating in it, and the malassezia is growing, and you basically just kind of get these hypopigmented lesions there. But it's treated, because it's malassezia, more like dandruff. So you treat it with the shampoos on the body, okay? So the anti-dandruff shampoo or the ketoconazole shampoo on the body. So it's not actually a tinea. Pretty simple. Okay, let's do some other things now. I want to talk a little about spirochetes. You'll see in this derm lecture, there's also a little bit of kind of infectious disease layered in here. Sometimes the infectious disease will have dermatologic manifestations, and I'll certainly point those out. But every once in a while, there's going to be a topic here with a little bit of ID that's not really much with the skin, okay? And it's just because there's not a separate ID section in the course. It's kind of distributed among the various sections. So let's just talk about spirochetes for a moment. Leptospirosis, who's seen this? I'll bet somebody has. 1, 2, 3. Where'd you see it? Hawaii. Back there? I see some nodding. Here we go. So Hawaii, about half of the cases of leptospirosis in the U.S. are in Hawaii. All right? So that kind of makes sense. So what's the deal with this? Leptospirosis is a little spirochete that causes bad things for you. So you're in Hawaii, and you're deciding to take a beautiful hike up into the hills, where you discover what you think is an undiscovered freshwater lake. And you think, this is beautiful, a little freshwater pond in Hawaii. I'm going to go swimming in Hawaii. And you go in there and you have a good time. And it turns out it actually wasn't undiscovered. Someone else discovered it before you. Someone who discovered it before you were the rats, the cattle, the pigs, these sort of things, who urinated into that pond, okay? So, and what's in their urine is this spirochete. And now you're swimming in this fresh water in Hawaii, and this stuff starts to go through your skin. Maybe you got a little abrasion or something like that. And the spirochetes go in through your skin and do what all good spirochetes do, which is disseminate. So it comes in through your skin, and then it disseminates throughout your body, and you get lots of bad things. And the things to remember with leptospirosis are hepatitis and nephritis. So it's going to inflame your liver, it's going to inflame your kidneys, so you get bad hepatitis and nephritis. But of course, it can disseminate all over. You get meningitis, lots of other things as well. Something called Weil's disease, which was originally described in sewage workers, is just bad leptospirosis. So it's the same thing, it's just really, really bad form of it, where you get hepatitis, DIC, subconjunctival hemorrhage, very, very sick. So that's leptospirosis. You die from hepatorenal failure. So again, liver, kidney, that's what you remember with leptospirosis. You diagnose it by serology. I wouldn't memorize the treatment for it. I think they probably wouldn't ask you that in the EM boards, but you just need to know about the disorder. Lyme disease, another spirochete. How many people have seen that? Yeah, a lot more, right? So as you know, this was originally described in Lyme, Connecticut, right? What was it, 1970s? There was what they thought was a cluster of what they thought was juvenile rheumatoid arthritis, but it wasn't, in kids. So they got a bunch of kids all living in Lyme, Connecticut, and around Lyme, Connecticut, that area, and they're all getting this really bad juvenile rheumatoid arthritis, very destructive. They're like, what's going on with that? That doesn't make any sense. So as they started to investigate it, of course, they figured out it was the spirochete, Borrelia, right? So it's Borrelia burgdorferi, the spirochete, transmitted by the tick bite. You all know this. And you remember, you start off with the fever, arthralgias, headache, and then you get your 3 stages. The first stage is the rash, which is the erythema migrans. Then you disseminate, because that's a spirochete. You get lots of complications, neurologic and cardiac complications. And then the third stage is that persistent, very destructive arthritis, which is where they were picking it up in these kids in New England. Okay. The rash, erythema migrans, annular, expanding, red lesion. It occurs where the tick bit you. So they bite you and it goes and starts expanding its way out. It's usually not on your palms and soles. Don't get a lot of tick bites on palms and soles. Think of it that way. Secondary portion of Lyme disease, right? You can get neurologic or cardiac. So neurologic, cranial nerve 7 palsy. That would be a classic exam question. In fact, if you see somebody with a bilateral cranial nerve 7 palsy, definitely think about Lyme as an etiology. But you can get a Lyme meningitis, you can get a peripheral neuropathy, you can get lots of neurologic complications. And then cardiac, you can get myocarditis, pericarditis, heart block. You get a 20-year-old female coming into your emergency department in heart block. That's not usual. You want to think about Lyme as part of the potential etiology there. You can do lab testing for it. It's not perfect. It's not the most reliable. So again, if you really think someone has this or you suspect it, just go ahead and treat. Doxycycline, you could use a MOX and other things as well, but doxycycline is the first line, and I'll leave it at that. So here's a picture, bless you, of Lyme disease. This is Erythema migrans. You can see it's an annular lesion spreading out, some central clearing going on there. That's classic. Again, Lyme disease, same type of lesion. This one looks like it's almost getting a little necrotic in the center, which apparently can happen. Okay, meningococcemia. You know about this? This can be bad, right? Bad stuff. Meningococcus, little gram-negative diplococcus, encapsulated gram-negative diplococcus, broad spectrum of disease. From everything from, believe it or not, occult meningococcemia, where a kid comes in febrile, looking okay, but's got meningococcemia. Wow, that's pretty scary, right? You don't want to miss that because that one's going to come back and be bad, but it can be really tough to catch. All the way to fulminant meningococcemia, which we've seen and is really a horrible disease. Again, fever, headache, myalgia, and then the rash. The rash are these little petechiae that can be all over the body and then start to become bigger and turn into purpura. And of course, it can become a vasculitis, an infectious cause of a vasculitis, so it can get basically every end organ in the body can become involved with this. Poor prognosis meningococcemia, other than just having it to begin with, right, is if you're hypotensive, no surprise, if you're highly febrile, if you have low platelets, if you don't have meningeal involvement, maybe that's because it progresses real rapidly, I'm not sure, and if you don't have a high white count. So if you have a low white count with meningococcemia, it's bad. You want a white count of 25,000 when you got meningococcemia. It's actually a better prognosis than if it's 6,000. Okay, what about prophylaxis and the deal with that? I mean, this happens, I don't know how, it seems to happen more frequently than I'd like in the emergency department. Somebody comes into the ED, you're working them up, you're treating them, they get admitted to the ICU or get more to the ward. Then you get the call. And the call is like, hey, just wanted to let you know that patient that you admitted earlier today, yeah, they're positive. Turns out they got meningococcus. Have a nice day, right? That sort of thing, right? Thanks so much. And we get that call, and then everybody, as soon as that happens, you get immediate onset of fever and neck pain. I don't know how that happens, just from the call, right? You're like, I don't know, my head's hurting, my neck's starting to feel stiff, and everyone starts freaking out and that sort of thing. Okay, so what about prophylaxis for this sort of thing? So first of all, the good news is it's not like highly contagious. Chickenpox is highly contagious, right? You walk by the room, you get chickenpox. But this stuff, turns out, if someone's got like meningococcal meningitis, for example, and you live with them, what do you think your chances are? This part won't be on the boards. What do you think your chances are of getting it? You live with the person who got it. 1 in 10, 1 in 20. It's actually 1 in about 250, okay? That's somebody who lives with them. So that right there should make you just feel a little bit better on your next shift when this happens to you, all right? It's like 1 in maybe 250 to begin with. But if you were exposed to this, yes, you still should get some prophylaxis. So this is transmitted by secretions, right? So if you were intubating or suctioning or having your hands in their mouth or examining, things like that, you definitely should get it. And even if you've just been around them and treating them close enough for a while, the prophylaxis is so simple, you may as well go ahead and get it. But this is not like a walking by the room, you caught it sort of thing, all right? So that should make you feel a little better. Post-exposure prophylaxis for this can be just a couple days of rifampin, or a single dose of Cipro, 500 milligrams, one time you're done. So again, if you're not allergic to it, you're not pregnant, I think it's like you open the Pyxis, you grab out the Cipro, and you give it out like Pez to everybody, you know what I mean? And then get back to work, and you're done with that. Pretty simple. Again, you know how to diagnose meningococcemia, cultures of the CSF or the blood or whatever you got going on where you think is infected. Treatment, you can use high-dose penicillin, you can use chloramphenicol, things such as that. Don't forget about our friend Waterhouse-Friderichsen syndrome. This is where you have meningococcemia and you get bilateral adrenal hemorrhage. So you get adrenal insufficiency because you have meningococcemia. So it was a bad day to start with meningococcemia, and it got a lot worse because now you have adrenal insufficiency as well. Okay, and here's some pictures of meningococcemia. Again, you can't tell just from this picture that that's what it is, but little petechiae and some purpura going on there. And this is what it can turn into. So really, really sad. You want to catch this early. By the way, every febrile kid that you examine from now and the rest of your career, make sure your chart says no rash. And if you want to be even more protective, say no rash, no petechiae, meaning I thought about that specifically, okay? Any febrile kid you see in your ED, make sure it says no rash. Again, assuming there is no rash. If there is a rash, you've got to put rash, all right? just to be clear. Okay, so that's meningococciemia. Necrotizing soft tissue infections. These are the flesh-eating bacteria, right? These are the ones you read about in the Journal of the National Enquirer or something like that, right? You know, leg eaten by alien or whatever, that sort of thing. So these are flesh-eating bacteria, toxin-producing bacteria, often seen with intravenous drug users. They can get, widespread necrosis of the tissues around them. You can get anaerobic cellulitis, with gas-producing and subcutaneous gas. You can get myonecrosis of the muscles. You can get necrotizing fasciitis, of course, where you get rapid dissection along the fascial planes. All of these are these necrotizing soft tissue infections. Neck fash, of course, is really important. Lots of different bugs that can cause this. It's a polymicrobial infection. The hallmark is pain out of proportion to exam. Got to remember that one. So they got a little infection on their arm or on their, let's say there's a right lower quadrant. It's got a little infection on their skin, but boy, they're tender and got a little pain going all up their abdomen, but you don't see much. That's neck fash. It's spreading along the fascial plane. Be very, very careful about that. Also, if you ever see, hemorrhage, ecchymoses, things like that, one of the things you have to be worried about as well. Pain out of proportion, you know that this is a surgical emergency. So, of course, you got to get on them really quickly with broad spectrum antibiotics. And this is not to memorize. This is just telling you to use broad spectrum stuff. But this is also a surgical emergency, so you want early surgical consultation. Again, you may pick this up on x-ray with some gas. You may use ultrasound and pick up gas. But watch out for this. You don't want to miss it. Fournier's gangrene is, remember, just essentially necrotizing fasciitis of the scrotum in men or the perineum in women. Okay, plain film. There's the subcutaneous air. There you go, gas producing. And there it is on CT. Again, I'm sure you've seen this, some subcutaneous air. Okay, MRSA. Let's talk about MRSA. Many years ago, and for those of you who've been practicing for a while, you remember MRSA was like when MRSA came in, it was like a thing. It was like, wow, oh, someone's coming in with MRSA. It's like a big deal, right? Because there wasn't this community-acquired MRSA like we see now where it's everywhere. It was just hospital-acquired. Someone came with MRSA. It was like, ooh, red alert, MRSA's coming in. We all got, excited about it. Hospitalized patients, intravenous drug users, dialysis patients, things like that. But now we've got community-acquired MRSA, and it's basically everywhere, right? So it's just not the excitement it used to be. But as you know, lots of skin and soft tissue infections from methicillin-resistant Staph aureus, meaning it's resistant to the first-line things that we used to use, like dicloxacillin or first-generation cephalosporins. So now we have to use broader things, right? So now for mild infections, we'll use things like clindamycin or doxycycline or trimethoprim sulfa, whatever, Bactrim, you know what I'm saying? Trimethoprim sulfa, don't want to say the word right now, I can't get it out of my mouth up here. And for more serious infections, you're using things like vancomycin, right? Or linezolid, or, what's the quinolone, delafloxacin, things like that. So there's stronger, bigger guns that you can use for this. Okay. This is all MRSA, whether it's a cellulitis or a furuncle or something on your arm or your lip or whatever infectious, all community-acquired MRSA. And again, you see this all the time, so it's not a surprise to you. Okay, let's do toxic shock syndrome. Remember this one when it first came out? Right? This was associated with prolonged tampon use, is what had gone on here. So this is a toxic shock syndrome. Is you have a Staph aureus kind of, I don't want to call it an infection, I'll call it a colonization or infection. You've got Staph aureus somewhere in your body going on that is producing this exotoxin that causes this syndrome. And it was initially described with these with tampons, prolonged tampon use, but it doesn't have to be tampons. It could be any sort of material sitting around the body, right? So surgical wounds, nasal packing, things like that we do. So you can get the staph growing there that can cause a toxic shock syndrome. So what does it look like? Well, it's toxic, meaning fever, shock, hypotension, and then syndrome is basically a diffuse red rash and multi-organ involvement. Okay, so toxic is the fever, shock is the hypotension, and syndrome is a red rash and a bunch of multi-organ involvement there, liver, kidney, GI, things like that. Okay, that's toxic shock syndrome. Treatment is, of course, you want to give them fluids. You want to get rid of the source, get rid of the packing, give them some antibiotics to get rid of the staph. Pretty simple. A trivia point that I want you to know for the exam is that there is a group A strep variant of toxic shock syndrome, so it's a streptococcal toxic shock syndrome, and the trivia point about that is that it tends to have a higher mortality than your classic, staph toxic shock syndrome. That's the only trivia to know about that one. Okay. Let's delve a little bit into some tick-borne infections because we've got about 5 minutes left here. And there's some interesting things to talk about. Okay, Rocky Mountain spotted fever. How many of you have seen this one? Let's see. All right, a bunch. I need people to shout out a little bit. Where did you see this? Just give me some states. New York? Oklahoma? Arizona, Indiana, Tennessee, Arkansas. Where are the Rocky Mountains, right? What's going on here, right? Rocky Mountain spotted fever. What's going on here? So it turns out that there was this guy, doctor named Dr. Howard Ricketts, who was hanging out in western Montana, and where they were having this outbreak of stuff, this disease that they called the black measles. Black measles, and Dr. Ricketts thought that this was because people were drinking the melted snow from the hills there in western Montana, from the mountains, I should say, in western Montana. But it turns out it wasn't. Turns out it was a little teeny bacteria that then got named after Dr. Ricketts called Rickettsia rickettsii, right? And it's a little bacteria that lives inside cells. So this was in the Rocky Mountains, and also the Rocky Mountain lab identified this organism. So this is Rocky Mountain spotted fever, but it's actually endemic to the southeastern United States now, southeastern United States, but it can be all over, but it's really endemic to the southeastern United States. So as you saw, lots of places that this happens, and mostly in the southeastern United States. Okay, tick-borne, bites you. What happens to you? Fever, headache, myalgias, and then you start with these little pink macules, and then it works its way into petechiae and maybe even purpura because it's a vasculitis. But the thing to remember about this is it starts peripherally. So the rash starts on the palms and soles, the wrists, the ankles, and it starts to move its way in, okay? It moves its way in centrally. So that's kind of the hint for your diagnosis and for the exam as well. It spares the face. It's not on your face. So it's extremities working its way to the trunk. Some lab hints on this. You'll have some thrombocytopenia, so some low platelets, which makes sense. It goes with your petechiae that you got going on there. You may have a low sodium as well. This is a clinical diagnosis. Don't wait for the serology. There is a serology that you should send off, but if somebody comes in, you get a 12-year-old who during the spring and summer, which is when it happens, they're out playing with ticks, which is in the southeastern United States, and they come in with you with this rash, please go ahead and get them started on some doxycycline. And I know we generally avoid doxy in kids, but if they got this, you want them to get it, all right? So doxycycline is the preferred treatment. Again, tick bite, little petechiae, purpura work their way from the distal aspects working in centrally. Because it's a vasculitis, it's the same complications you get with all vasculitis, right? DIC, you start to infarct things, right? Loss of limbs, CNS, lung, kidneys, it affects everything. Okay, so here's somebody, they were out in the spring and summer, play with ticks, got the tick bite, and they got these little petechiae. They start on the palms and on the wrists, and ooh, look, it's progressing proximally. Going up the arm, going up there. That's Rocky Mountain spotted fever. Doxycycline, clinical diagnosis. Okay, ehrlichiosis. I know, you're thinking like, what? Just like, kill me now. Like, do I have to, like, what is this about, okay? But this is not so bad, okay? Ehrlichiosis, just think of it as spotless Rocky Mountain spotted fever that also infects your white cells. And you'll get this right on the exam. So what is this? It's very similar. It's also a tick bite. It's also a little bacteria. Okay, you also get fever, headache, myalgias, and a rash, but instead of getting the spots like Rocky Mountain spotted fever, you just kind of get this diffuse, red maculopapular nonspecific thing that you're not going to figure it out by just looking at it, okay? So it's kind of a nonspecific rash. And just like Rocky Mountain spotted fever, you're going to have low platelets and may have a low sodium and things like that, but because this infects your white cells, you're also going to have low white cells, okay? Diagnosis, similar. Treatment, same thing, doxycycline, clinical diagnosis, put them on doxycycline, same complications. So it's just like Rocky Mountain spotted fever. It's just like instead of having spots, you got a nonspecific rash, and you also can have a low white count because your white cells are infected, all right? So now you know ehrlichiosis, and you'll get that, hopefully one, my gosh, you can't have more than one question on that on the board exam, could you? That would be just cruel, right? So you'll get that question right now. Okay. I think because of time, I'm going to stop because I don't want to run over. So we'll stop with that. We'll pick up on babesiosis on part 2. See you soon. Thanks.